Hello everyone, this is Dr. Oliver. I have created an antibiotic review series, so this will be episode 1. I had to kind of split them up just because the PowerPoint presentation ended up being a little bit longer than what I had originally anticipated, but I feel like it has lots of great information for you to review. So I think that will be helpful for you now and then also later on when you are going to study for your certification exam. So in this first episode, we will talk a little bit about why prudent antibiotic prescribing is necessary. We're going to talk about superbugs and what those are and what they mean. And then also talk about how we can avoid the development of future superbugs. So why is it important that we're careful with who we prescribe antibiotics to and what we're prescribing it for? So since the discovery of penicillin in 1928, antibiotics have been a critical component for the treatment of infections. I'm sure you guys see this wherever you work, whether it's in the hospital or outpatient. You see patients that come in, they're diagnosed with some sort of bacterial infection and they're prescribed an antibiotic. So the emergency of drug resistance in bacteria has been climbing over the last 80 years, however. So drug choices for many bacteria infections are becoming more limited and very expensive as well. Some experts are predicting that superbugs will kill more people than cancer by year 2050 if more aggressive steps are not taken. Now, I don't know about you guys, but when I was looking up this information and I saw that possibly superbugs could kill more people than cancer by year 2050, I was a little surprised. And to be quite honest, that's a little scary as well. But looking back at the people that I take care of in the hospital, I can see where this is already starting. The majority of the people that I have coming in now, they're not coming in with simple infections. They're coming in with very difficult to treat infections, and sometimes we have to change antibiotics once, twice, maybe even 3 times on a single patient because the bacteria changes and we have to be aggressive in how we treat it. So it is important to understand that bacteria is very smart, and so as prescribers we have to be even smarter than the bacteria. So we really have to make sure that we're prescribing antibiotics only when needed, and we need to make sure that we're prescribing the appropriate antibiotics for whatever we are treating. I'm sure many of you have heard this talked about. I'm pretty sure we talked about it last semester as well, but new antibiotic development has slowed to a standstill, and a lot of this is because of market failure and regulatory disincentives. Really, antibiotics are just not as profitable as other drugs. So right now, the big ones that give a lot of profit are like the obesity medications, the heart failure medications, COPD, anything for COPD, asthma. You think of how expensive those medications are. Imagine how much a company is making off of those medications that people are buying. And then you go and look and see how much Keflex is at Walmart or Cipro even. I remember even 5 years ago, I would say Cipro was probably $20, $30 more for a 5-day supply than what it is now. So antibiotics really don't make a lot of money for these companies, and so that's a disincentive for them to create more of them, which is unfortunate. So the FDA even delayed publishing workable guidance documents describing how companies should design antibiotic clinical trials. So we need to kind of catch up with our need. This is a need. I mean, we have enough of these superbugs developing that we need more antibiotics. So what is a superbug? So a superbug is an organism that shows significant antibiotic resistance, usually to 2 or more classes of antibiotics. Now, I'm sure some of these on here are familiar to you, especially if you're working in the hospital currently, but these are all considered superbugs. And so I made this list for you so that you guys are aware, when you have a patient that tests positive for one of these, then we do need to be a little bit more cautious with them, and we need to monitor them a little bit more because we don't want to create an even bigger superbug, and we don't want this to spread and to other people as well. So it's important to know what are your superbugs and what are they capable of. So I would keep this list. So we started talking about this a little bit, but one of the reasons why superbugs are becoming such a big issue is because of poor antibiotic prescribing. So poor antibiotic prescribing puts patients at a higher risk, and about half of the hospitalized patients receive an antibiotic for at least one day during the course of an average hospital stay. And I will tell you, a lot of these patients, they come in and they don't necessarily need the antibiotic, or they don't need as strong of an antibiotic as what everybody thinks they need. So for example, I had a patient a couple of weeks ago that because of the sepsis criteria and what he came in with, he triggered that sepsis alert within the system, and it turned out that he didn't even have sepsis. What ended up happening is that because of this sepsis alert, they initiated the Vanco, the Zosyn, all of these things, and he ended up not even actually needing them. So this is an example of how, sometimes people will get these, big gun antibiotics when really we probably could have dealt with it, something a little bit more simpler. So the most common types of infections for which hospital clinicians wrote an antibiotic prescription for were lung infections, and that's at 26%, urinary tract infections, 14%, and then suspected infections by MRSA, 17%. And I would say we probably, in the hospital, we see more of this than the outpatient, because I think everybody is nervous about MRSA. If there is a suspected case of it, we all tend to overprescribe in the hospital, more so than I think in outpatient. Over half of the antibiotic prescribing in outpatient settings is unnecessary, and most of the inappropriate use is for acute respiratory infections. And we talked about this last semester too, but the pharyngitis, the sinusitis, the bronchitis, not all of these need an antibiotic. So it's really important to get a good background story for these patients that you're seeing and find out, is it really necessary that we put you on an antibiotic? So let's talk a little bit more about antibiotic resistance. So resistant bacteria or their genetic determinants are selected when colonizing or infecting bacteria are exposed to antibiotics. So basically, these bacteria have the capacity to mutate or to change. It's in their genetic code. So when they are exposed to different antibiotics, and perhaps that antibiotic is not appropriate for that specific bacteria, then it allows the bacteria a chance to make itself stronger. So when you do actually prescribe the right antibiotic, it's had a chance to kind of muster its strength up, basically, and now you have a more difficult bacteria to treat, and perhaps that antibiotic that you're prescribing now that should have been prescribed at the beginning won't be appropriate anymore for this bacteria. So it ends up going into this, downward spiral. So resistant bacteria can be transmitted between patients. So this is important to know, because when you are dealing with immunocompromised patients, hospitalized patients, or patients with any sort of invasive device, these are the patients that it tends to be transmitted to a little bit more easily. So we have to be cautious with them. The single most significant factor in the development of resistant organisms, though, is antibiotic usage. So as providers, there are four main mechanisms by which microorganisms can create resistance to antimicrobials, and it's important that you know what those are. So the first one is drug inactivation or modification. And just an example of that is the enzymatic splitting of the penicillin G molecule by penicillin-resistant bacteria through the production of the beta-lactamases. So that is like when we talk about amoxicillin, how some bacteria will inactivate a portion of that antibiotic, and that's how Augmentin came about. And so it's important to understand that certain parts of the drug can become modified or inactivated by certain bacteria, and that's how they create a resistance. The other one is changing the target site. An example of this is altering the binding site of penicillin, especially in MRSA and other penicillin-resistant bacteria. So it kind of confuses the antibiotic, and the antibiotic does not go and take care of the bacteria infection in the location that it needs to. The third one is changing the metabolic pathway. So some sulfonamide-resistant bacteria do not need the para-aminbazole acid, or the PABA is what it's labeled as short, for the synthesis of folic acid and nucleic acids. And then the last one is decreased drug concentrations. So decreasing the permeability of the bacterial cell to the antibiotic, or increasing the excretion of the drug from the cell surface. And this one is important because I think this one tends to be the more common, this one or the drug inactivation or modification. And these bacteria, it's amazing to me, and I don't know if you guys remember back when you took microbiology, but it's amazing to me how smart this bacteria is, and I really don't think that we give bacteria enough credit, because for it to be able to make these little subtle changes and to inactivate a drug, or change the target site, or change how things are metabolized, or change the drug concentration, that's very strategic. So we have to be strategic in how we prescribe these antibiotics to our patients. So how can we fight this resistance? We've kind of talked a little bit about this, but we can prevent infections and prevent the spread of resistance. So it's important to talk about hand washing, and not just hand washing, but appropriate hand washing. How long should a patient spend washing their hands? What type of soap should they use? And, those type of things, because, some people, they just come in real quick and they, wash their hands for a second and go out. But if they are more prone, say they're immunocompromised, or perhaps they have diabetes, or they, have a invasive device, say they're a kidney patient, then these patients need to be educated on how to prevent infection and how to prevent the spread of resistance if they already have a resistant bacteria. We also need to track resistant bacteria, and this is really important, because you'll find that resistant bacteria clusters in communities. So once you start practicing, it'll be really important to look up what resistant bacteria is present in the community that you'll be caring for. And this should influence what antibiotics you end up prescribing. We also want to improve the use of today's antibiotics. So we want to use them for what they're intended to be used for. We don't want to just prescribe antibiotics because our patients are demanding them. We want to actually sit down and have a conversation with them and educate them on why the antibiotics are important and why they wouldn't be, and then use those antibiotics appropriately. We also want to promote the development of new antibiotics and develop new diagnostic tests for resistant bacteria. And so this is where it's important for us to be involved in policy change, and also to be involved in just keeping up with the latest research. If there's any way that we can kind of jump in and be advocates for this issue, then it's our responsibility as healthcare providers to do that. So here are some of the most common reasons for inappropriate antibiotic prescribing. Number one is diagnostic or uncertainty and fear, and I would say this is probably one of the biggest when new grads are out practicing on their own, because all of a sudden you don't have somebody to fall back on as much as you did when you were in clinical. So there's a little bit of uncertainty, maybe a little bit of fear of prescribing the wrong antibiotic for that particular patient. So this is something that I will tell you, it will come, or it will get better with experience. However, just be aware, this may be something that you experience when you first are on your own. Number two is a knowledge gap. And again, this kind of comes with being a new grad on your own too. Things are going to be new to you. This is going to be a new role to you. So you have to give yourself a little bit of slack, just to know that you may have a little bit of a knowledge gap at first until you're able to gain that experience. But how you counteract that is how to utilize your resources. So it's important, you can use UpToDate, you can, use resources that your place of employment has available to you. And it's important to ask about those when you're interviewing, what is provided to me. So you want to try to compensate for that knowledge gap. The third one is indiscriminate lab testing. And this ends up being more of an issue depending on where you work. And then the last one is inadequate documentation and transitions of care. I will say I noticed this a lot when I was first doing primary care, and I was doing primary care in a rehab facility. So many times these patients would come from the hospital, and some of them were discharged perhaps a little too early, but besides that point, a lot of them came with just really inadequate documentation. And so, I didn't know the exact day they had started the antibiotic in the hospital. Sometimes I didn't even know how long they wanted that antibiotic to, go on. It really makes it hard to have a proper transition of care when your documentation is not adequate. So, and that's why I know you guys probably don't really care for the clinical reflections, but that's why we have you guys do those, and we do make them on purpose a little bit more detailed, because it is always better to be more detailed than to not be detailed enough. And I think that's something really important to remember when you're practicing on your own. So let's talk about misuse of antibiotics. So incorrect diagnosis, and this happens sometimes, and sometimes there's no way around it, and it's not necessarily that you did anything wrong, it's just perhaps you didn't have all of the information that you needed. So antibiotics, or what this means is antibiotics given when the infection is viral and is not needed, or antibiotics given without symptoms, such as an asymptomatic bacteriuria, and then treating colonization or contamination, so it's not an actual infection. And a lot of these will come with experience. You may incorrectly diagnose somebody in the beginning, and it's you learn from that, you move on from it, you correct it if you can. Hopefully nobody gets hurt, but you utilize your resources, you utilize your collaborating physician, and you just move on and you learn from that. Incorrect prescription. So the wrong antibiotic is given to treat an infection, given at the wrong dose. So subtherapeutic dosing is usually the biggest issue. And then broad spectrum agents used to treat a bacteria that are susceptible to many other narrow spectrum agents. This also will come with experience, and so it's important. This is why I actually like up to date, because for me, up to date is it's very detailed, but it's very succinct. So I know exactly what is the first line, what is the second line for specific bacteria. And for me, that really, it helps me prevent an incorrect prescription. So I would highly encourage you to continue to use up to date, or you can actually, even once you're out of here, you can individually purchase some of the apps in the Nursing Central app that we have for you. And so just keep that in mind. That might be something that you can negotiate with wherever you work at. The third one is no de-escalation. I see this a lot in the hospital. So continuing antibiotics when they are no longer necessary, or continuing IV antibiotics when the patient can tolerate an equivalent oral antibiotic. And that last one is probably what I see the most in the hospital. A lot of the times when people are in the hospital, we just think they need IVs. That they're in the hospital, so they need something IV. And that's not always the case. We're doing them a disservice. So if we can transition people to oral antibiotics as soon as they are able to take those antibiotics, we'll be doing them a better service by doing that. Fourth one would be patient issues. And this one, especially I feel like out in the outpatient realm, or if you're in the ER or the urgent care, you're going to run into this. So not completing the full course of the antibiotic, keeping antibiotics at home just in case someone in the family needs them, and then doctor shopping to find a provider that will prescribe antibiotics, and then not staying home or away from others when ill. So I will tell you, my mother is horrible at this, and she will very frequently stop antibiotics early despite me telling her not to, but she does this so that she can keep some of the antibiotics at home just in case someone in the family needs them. It's a horrible thing to do, and I have talked to her about this, but you will find more patients that do this than not. I will tell you, doctor shopping has been an issue in Marion, and that's why it's unfortunate now, but now a lot of the doctors in Marion, a lot of the primary care and family care physicians actually go through an interview process with patients that are trying to get into their practice, and they do this on purpose because people in Marion doctor shop because they try to find a provider that will give them what they want, and a lot of the times it comes down to antibiotics. So the last one is agricultural issues. Use of antibiotics in livestock to prevent disease. Low-dose antibiotics have also been associated with a method for animal weight gain. And then it is thought that resistant strands of Salmonella, and then some of these other ones, they've been transmitted from animals to humans. E. coli is another big one. So it's just important, this goes back to what we're putting in our bodies, and not that I am perfect by any means, because, sometimes I guess you buy what you can. And if you have patients that are more low income, they really just buy what you can, or buy what they can. It can't be anything really expensive. However, we do need to look at the use of antibiotics, especially in our dairy products. This is just something to keep in mind. And, as this issue continues to become more of a problem, we may have to come back and look at this more as health providers as a whole. So there's 3 questions to ask yourself prior to prescribing an antibiotic. Number 1 is, does the patient have an infection? Is it bacterial or is it viral? These are questions that a lot of the times we can gather the answers from doing a very, very thorough subjective history. And then if we need to, we can add in objective data like a UA or a CBC, something like that. But we need to ask ourselves, does the patient have an infection? Number 2 is, what is the patient most likely infected with? So think of what organism could be causing this. What is the site of the infection? Where are the symptoms at? Where are they stemming from? Because we won't treat a lung infection the same as we would a urinary infection. So it's really important that we pinpoint exactly what we're treating. Number 3, what is the preferred treatment? So it needs to be patient specific. And then the length of treatment with a specific stop date needs to be identified. And like we talked about earlier, so utilizing your resources, use up to date. Up to date is so nice because it has the first line, it has the second line, it tells you how long you need to continue these antibiotics. And Hippocrates does a decent job with that as well too. It doesn't necessarily have the first line, second line, but it does tell you the average length of treatment time. So utilize those resources to pinpoint exactly what treatment you need to prescribe for whatever the specific organism or site of infection is.